Good morning. My name is Dr. Roland Gray, and since January of 2002, I have been the medical director of the Physicians Health Program here for the state of Tennessee. We've been in business now for over 35 years, and during that time have worked with over 5,000 physicians and their families. In the early days when we first began, almost every physician that we worked with had either an alcohol or a substance use disorder. Today, that's only about half the physicians that we work with, and we attempt to assist physicians with whatever difficulties they're having in their life. But today, I wanted to address specifically the problem of alcohol and drug use by the physician group as a population. And I'll start out by saying that the incidence of alcoholism and drug addiction in the physician population is not decreasing. The Federation of State Medical Boards in 1955 first called for the creation of physician health programs. At that time, and really up until the late 1970s, the only avenue for a physician who was in difficulty with alcohol or drug use was a disciplinary track through the medical board. In other words, they took their medical license, put sanctions on them, and there was really no attempt made to rehabilitate these physicians. In the late 1970s, there was an article that came out in the Journal of American Medical Association entitled "An Epidemic of Physician Suicide in the State of Oregon." What that article entailed, there were 40 physicians who were under investigation by the Oregon Board of Medical Examiners, and during about a 15-month period, 10 of that 40 attempted suicide. 8 of them were successful, and 2 of them survived very serious suicide attempts. And it was at that time, I believe actually that article had a lot to do with the creation of our physician health program and other physician health programs around the country. Today, Tennessee has one of the oldest and most successful physician health programs. And as other states have gotten started over the years, they have looked to Tennessee as a model. To give you a little historical perspective on the problem of alcohol and substance use disorders, this is a little background on Dr. William Halstead. Probably everyone in this audience knows of Dr. Halstead. He started the first surgical training program at Johns Hopkins. He did one of the first cholecystectomies in the United States, one of the first blood transfusions. He was the one that developed the gloves that we use, the protective gloves that we use in surgery. His wife was a scrub nurse, and she had a reaction to some of the reagents that were being used in surgery at that time. And he actually had the gloves developed to help her with her dermatitis. Like a lot of things in medicine, they found out a few months later that his cases had many fewer infections, and it was shortly after that that everybody began to use latex or rubber gloves in surgery. In spite of all the contributions Dr. Halstead made, he was addicted to cocaine and morphine throughout most of his career. This slide is from the inner workings of the Johns Hopkins Hospital. In 1884, Dr. Halstead read an article in a German medical journal which talked about the use of cocaine as a local anesthetic in the eye. He and 4 others of his colleagues began to experiment with cocaine as a local anesthetic and a regional nerve block by injecting themselves. Unfortunately, he and 3 of those physicians became dependent on cocaine, and in 1886, Dr. Halstead was treated at the Butler Sanitarium for cocaine addiction. He was placed on morphine at that time, and I might add that cocaine and morphine were not illegal substances at that time, and he was placed on morphine to wean him from the cocaine. But in spite of getting some of the best treatment that was available at that time, he remained dependent on cocaine and morphine throughout most of his career. This talks about the etiology of chemical dependency, which is the broad term for alcohol and substance use disorders in physicians. A lot of physicians are loaded genetically. They come from families where there's a history of alcohol use disorders. And this genetic vulnerability, combined with the psychosocial stressors of practicing medicine, particularly today, leads to experimentation and treatment of the psychic pain with alcohol and these other drugs. The stress may lead to self-medication. A lot of our physicians begin to get into difficulties by self-medicating themselves, and hydrocodone and alcohol are the most commonly abused substances by physicians. And I might add that tramadol, or Ultram, which has only recently been a scheduled drug in the state of Tennessee, is the second most commonly abused drug by physicians. We abuse alcohol at roughly the same rate as the population at large. It was thought at one time that physicians had a higher incidence of alcohol abuse, but we know now that statistically it's about 10%. We are actually less likely to use illicit drugs, but have a more likely incidence of abusing prescription drugs than the population at large. And a lot of this has to do with the easy availability of these drugs. They are given to physicians as samples. It's easy to obtain them, not always in a legal manner. But at any rate, once a physician becomes dependent on these drugs, it's not hard for him or her to continue that abuse. This is an old study that during a one-year period, there's a little over 10%, about 11.4% had abused benzodiazepines in the past year in an unsupervised fashion. In other words, they had treated themselves with benzodiazepines. And over 17% of them had engaged in the unsupervised use of opiates. In other words, over 17% of them had self-medicated themselves with opiates. And that physicians are 5 times more likely than the population at large to take sedatives and minor tranquilizers without medical supervision. Most of the physicians that we deal with, the slippery slope begins when they begin to treat themselves for a mood disorder or a physical ailment. One of the difficulties that we deal with in medicine is that our colleagues are very reluctant to confront a substance abuse problem in a physician. There's still a lot of what we call white coat silence, a tendency to look the other way, hoping the problem will correct itself. And unfortunately, because of this reluctance to confront a colleague, that sometimes death by suicide or a lethal overdose may be their initial presentation of a substance use disorder. These are some of the symptoms of alcohol or drug abuse that's seen in physicians, principally in the workplace. The most commonly abused drug by physicians is hydrocodone, followed by alcohol, and most of the physicians that we see are abusing a combination of hydrocodone and alcohol. Hydrocodone remains the most prescribed drug in the state of Tennessee, and with physicians and really all health professions, it's the most commonly abused drug. The smell of alcohol on the breath of a physician, either when they're called in to the emergency room or to see a patient, or they come into the OR, is a frequent reason for referral to our program. Being red-faced, having prominent capillaries over their cheeks and nose, bloodshot or glassy eyes, excessive use of eye drops. We particularly see this with marijuana abuse and opiate misuse, and wearing sunglasses indoors. They frequently will have unusual pupils, either constricted or dilated pupils, and will be seen to be sweating in a room that's comfortable to everyone else. They self-medicate, and most of them do have legitimate medical problems, but they don't seek help for their medical or their emotional problems, and instead treat themselves. There may be memory lapses or blackouts. This is very common with physicians who are abusing alcohol or sedatives, and the physician may not actually be impaired during the period that they have the blackout. They're practicing medicine, and I might add that medicine is really the last thing to go in physicians' lives. By the time they have developed full-blown substance use disorder or alcohol abuse disorder, most of them have lost their families and other areas of their life that are important to them. During the blackouts, the physicians do things. They come into the hospital, they'll write notes, and the next day they'll have no recollection of that behavior. There will be a deterioration in their reliability. It's very common for physicians who have an alcohol or a substance use disorder to have gone years without complaints from patients or nursing staff, and all of a sudden there's a flurry of complaints by their patients or the ancillary staff. They have slow, slurred, or pressured speech. They'll avoid close contact or interactions with others. They avoid eye contact. It's very common for physicians who have a substance use disorder to make rounds at unusual times. They'll come in and make rounds in the middle of the night. There'll be patient complaints about that and complaints for their families. And they do this because they know that there's a skeleton crew around and they're less likely to be detected. Their behavior becomes erratic. They have mood swings. They may begin to get a lot of complaints because of disruptive behavior, and their affect becomes inappropriate. Many of these physicians will start to lie or be dishonest, and a lot of times this is because of the blackouts that they're experiencing. They simply don't remember what they had done the day or the night before. They may have tremors, their hands will shake, and the withdrawal, frequently physicians are seen during alcohol or drug withdrawal. And the withdrawal of any drug or substance, mind-altering substance, is the mirror image of that. So if the physician is abusing alcohol or sedatives, rather than being sedated, he will be very jittery, he will have tremors, again, have the mood swings. They may not answer when they're on call. This is very common for the physicians to not be available by phone, don't return their pages, or they may answer it and come in and they're obviously impaired. They may miss work frequently or be late. Again, they generate a lot of patient complaints. They'll either be very late to see their patients or they just don't come in at all. They become very defensive when confronted. They minimize regarding their alcohol or drug consumption. And they use a lot of fragrances and or breath sprays to cover up the alcohol on their breath. And they may actually have alcohol in their possession in their car or at work. Now, how can the Tennessee Medical Foundation help if you have a physician that you're concerned about? And let me say that the work that we do is confidential. We have relationships with the Board of Medical Examiners, with the malpractice insurers in the state, so that if a physician is known to our program, we can keep that physician on what we call a confidential track, so that they're able to enter our program, complete their contract with us, and re-enter the practice of medicine so that no action is taken against their privileges or their license. First of all, an identification is made. Once an identification is made and reported to the Physician's Health Program, and our contact information will be at the end of this presentation, we get collateral information. We may obtain this from their coworkers or their hospital. We may get information from the Controlled Substance Monitoring Database. If we can get enough information on this physician, we will have them undergo an assessment. And this assessment may be anything from a 1-hour meeting with one of our approved assessors, or up to a 4-day hospitalized assessment. During this time, the physician is tested for alcohol and drugs, psych testing, neuropsych testing is done, interviews are done with their colleagues, with their families. And at the end of this, if the physician is found to have a substance use disorder, they will be referred to one of our treatment facilities. Treatment may be anywhere from intensive outpatient or meeting with individual therapists up to long-term residential treatment. Following their treatment, we sign a contract with these physicians. The standard contract for physicians is 5 years, and during that time, we will assist the physician in reentry and provide advocacy for the hospital, for the health-related boards, or anybody else that it's required for. These physicians on their contract, they will meet with me upon completing treatment. They're assigned to a case manager in our office. We do random, unannounced, observed urine drug screens over that 5-year period, which decrease in frequency as time goes on. They're required to go to a certain number of 12-step meetings during the week. And each week we have caduceus groups around the state. We now have them in 12 cities around the state. And these are physicians who themselves are recovering from alcohol or substance use disorders. And they will meet weekly with that group. And at the end of that time of 5 years, the physician is released from their contract. Now, what we're able to do for these physicians, we have, if you look at these physicians long term, there's only about 4% of them that are unable to return to the practice of medicine and complete their careers. So we look at about a 96% success rate. Only about 10% of the physicians that we work with will have a relapse, and most of those we pick up early during their monitoring period. This shows our contact information. The work we do is confidential. If you know of a colleague that you suspect or know is struggling with an alcohol or a substance use disorder, I would encourage you to contact the Tennessee Medical Foundation. We're just here to help physicians, and the call you make or by reaching out, you may save these physicians' lives. Thank you all very much.